All right, we'll go ahead and get started. Good morning, everyone. Thank you for joining us today on this Telehealth 201 session. My name is Ray Dizon. I'm the project coordinator for the National Consortium of Telehealth Resource Centers. I'll be the moderator for this session. A few housekeeping rules. We have turned off everyone's audio and video except for the panelists. We do encourage you to use the Event Mobi app Q&A function to ask your questions. If you see questions similar to your own, please use the upvote feature, and that's how we'll be triaging the questions. I'm not going to be going over the presenter bios. Those will be also available on the Event Mobi app. But today I'm going to introduce our presenters. First, we have Laura Octay. She is the Telemedicine Operations Manager at the University of Virginia Health System. And then we have our second presenter, Rob Sprang, Director of the Kentucky Telecare at the University of Kentucky UK Healthcare. So I'm going to go ahead and pass it over to our presenters.
Thanks, Ray. Guys, I'm gonna start this. I'll do the first half of the presentation. Laura will do the second half, and we should have plenty of time for questions and answers. Laura, if you can do the next slide, please. One more back, and now I think everybody has probably read the session description, but hopefully this will be the natural progression if you went to the Telehealth 101. But we'll talk a little bit about strategy, C-suite buy-in, and also talk about policies, procedures, and workflows and processes. Or if you go to the agenda, please. And so this is the agenda. I'll take the first session, part of the session, which is the strategy. Laura and I will both speak to the telehealth department, kind of the organization, whether it's centralized or decentralized, and then Laura will pick up with the workflow and processes. Next slide, please. So from the perspective of why to do telehealth, none of these are very good reasons. Although I gotta say, I do like New Amsterdam. That's a pretty good show. But these are not good reasons to do telehealth. Now we're gonna kind of stay away from the whole COVID-19 issue because it is somewhat transient in our industry, but it is the most impactful thing that's happened in telehealth and I've been doing it 25 years, and I would say in 25 years. So what we didn't put, and a good reason to do telehealth, is COVID-19. You will see for most people that are in the industry, it is the one thing that has kickstarted telehealth more than just about anything else we've ever seen. Next slide. So the best answer of why to do telehealth is because it's part of your organization's strategic plan. To drive telehealth from an organizational strategy is probably the best reason to do this. And some of you may not have that. So we could go to the next slide, please. The University of Kentucky added telehealth to our 5-year strategic plan in 2015. And so it was actually written in. So we go to the next slide, I'll show you. And I apologize that I had to redact most of this because the university is really not ready for me to put our 5-year strategic plan out there for everybody. But if you look at this, there are 11 tactics that are on the board. And of those, one of them is telehealth and community care. So the most important part of this strategic plan from my perspective is item number 4 under the blue heading, and that's the telehealth and community care. So it is written in to the strategic plan. It drives us forward. Next slide. And if it's not written in your strategic plan of your organization, you have the opportunity to still impact your strategic plan just by proving the value of telehealth. And there are, I've put out 4 different ways that you can do this, from clinical education, clinical programming, education, research, and administrative support services. From a clinical perspective, you can enhance outreach. And I doubt if any healthcare system does not have outreach as part of their strategic plan. You can facilitate relationships with referring providers. And again, that resonates with every health system. As we move to a value-based model of payment, reducing unnecessary emergency room visits and especially readmissions is going to be on everybody's mind. You can pursue high revenue clinical contracts such as employer health, corrections, different state agencies. And as we've all seen with the COVID-19 crisis, the use of direct-to-consumer telehealth to reach out to new patients. Educational programming is important. If you're an academic medical center, you should be using video conference technology to enhance your student and resident experiences. You should be providing training for community-based healthcare professionals. These are the people that are referring to you. And then also to educate patients as well. Again, as an academic medical center, research and external funding opportunities are critical for us. And telehealth can offer a competitive advantage for research and health and grant programs. And then finally, administrative support services. And it's easy to look past this as not important, but especially as healthcare systems begin to divest themselves into different locations, video conference technology can just reduce the cost and inconvenience of travel just for simple meetings. We use it for job search interviews, for depositions. And I think what we've all found through the COVID-19 crisis is that most of us are working from home now. And without this video conference technology, how could we function without team meetings and programs like that? And so you can support other aspects of your organization's strategic plan. I'll walk you through the next slide. Now, while the University of Kentucky would not want me to put our strategic plan online, the UC Davis health system does. And this is their strategic plan. And I realize that you can't read all this, but I want to give you an example of if your health system does not have telehealth specifically written into the health plan, you still can have an impact on that. And again, if you prove over time to have an impact on the strategic plan, at some point, you may get written into that strategic plan. Now, I find it really interesting that UC Davis has one of the strongest telehealth programs in the country. We all know that team, and they do some really good work. And yet, as strong as that program is, they just have chosen not to write telehealth into the strategic plan. But I'm going to go through this with you so that you can see how you could go to your organization and help with your strategic plan. So, next slide, please. So if you look at your organization's strategic plan, in this case, one of their themes is lifelong health. Well, I can tell you, we do telehealth from with young women, especially low-risk OB patients, as well as high-risk OB patients, all the way through memory disorders and programs for the very old. So the idea of using telehealth for lifelong health makes complete sense. Next slide, please. And affiliations and partnerships. And again, as we said before, everybody's strategic plan is probably going to have something related to affiliations and partnerships, and that is exactly what telehealth helps you do. Next slide. And then the idea of community and rural health. Again, I can't emphasize enough that every medical center, especially larger medical centers, are focused on how do we reach the community, and in this case, rural health, and that's exactly where telehealth can help you. So you can show your senior leadership, this is how I can impact the strategic plan. Next slide. And health system access and financial viability. The expansion of access to healthcare is exactly what telehealth does. So this is another place where you could impact this strategic plan. Next slide. And this is the other half of their strategic plan. So enhance partnerships and value collaborative successes and achieving goals. Again, we've talked about this, but enhancing partnerships is exactly how you can use telehealth. Next slide. And recruit, develop, and retain accomplished and diverse faculty and staff. Now, this is going to be much more closely focused to academic medical centers, but this talks about how faculty, staff, students, residents, the trainees can all benefit from telehealth. And I think what you'll find is that with the influx of foreign-born and foreign-trained faculty, staff, students, residents, there is a real desire by these people to go back and help at home. And that's something that telehealth can help you do, is to allow them to reach back to their country of origin or to their training program of origin and let them assist them. So you really should try to leverage your telehealth program for that. And next slide, please. And then expand access to cutting edge technologies and information services. I mean, that's what telehealth is. And so here's an opportunity to tell senior leadership that my telehealth program, while not written specifically into the strategic plan, has the opportunity to support all these different aspects of the strategic plan. Next slide. So how do you assess new telehealth services? And I will focus specifically on University of Kentucky and what we did, but before 2015, our outreach services were not well coordinated. We had my telehealth department that would go out on our own and work with community providers. But you also had senior leadership at our organization. We had a physician liaison program, which is not unusual, and their job was to go out and recruit partnerships. Every department and division had their providers and their administrators doing their own outreach. You had our Department of External Affairs that traveled all over the state making contacts. We developed something called the Kentucky Collaborative, which was the 50 biggest hospitals in the state, and we created the supply chain initiative between that group, and it was another outreach service that was coordinated through an entirely different group. And then you had everybody creating these informal partnerships and arrangements. The problem was we were stepping over ourselves, people going out to the communities and talking to them. And the telehealth program launched most of our new telehealth services, and we had limited governance on outreach, and we really had limited recognition about what the telehealth program was doing. We were just not at the table, and senior leadership often didn't recognize the work that we were doing. Next slide, please. And so an outreach committee was formed in 2015, and it included external affairs, strategy, legal, contracting, compliance. It had ambulatory leadership as well as the telehealth group. And we created definitive processes to propose and present and then vet all new outreach ideas. And then we had additional approval from IT governance and the executive leadership team. So it created a very specific, very detailed evaluation of all new outreach initiatives. And then in 2017, we actually created a telehealth steering committee. And so new ideas that were bubbled up for telehealth had to go through the steering committee. Once it went through the steering committee, it was presented to the outreach committee. And the steering committee used the Gartner Group's decision framework for virtual care services. We suited it, or we modified it to suit our needs, but I cannot say enough about that. If you are a Gartner Group customer, you need to look at this decision framework for virtual care. It's really a first-rate design that you can implement for yourself. And we'll talk a little bit further about that now. Next slide, please. So we have a new program checklist. And again, I'm not saying that you necessarily need to follow my checklist, but that you need to create something that has some structure to it. So in our case, we have a planning phase, a governance phase, development, launch, and then follow-up. And each one of these has very specific things that you need to follow. But the very first thing in the planning is that we complete that strategic framework document. And again, that document is what we pulled from the Gartner Group. And then you can see how this passes through the chair and chief of the department. And it was really surprising because there were clinicians that would come to us with new ideas that had not even vetted this through their own department division. So that's one of the first sign-offs that we have. Then it goes through the steering committee, it goes through the outreach committee, and then if there's any new technology that needs to be purchased or any capital that is going to be required, it has to go through our IT governance group. And then it passes through and you can see the rest of the project. Again, I think all these slides are going to be available, so you'll be able to take a look at these. Let's go to the next slide. So the decision framework for new applications. Now, guys, I'm going to give you a couple of pieces of this. Again, the Gartner Group requires you to be a customer in order to get access to this. I think you'll find that many large health systems already are Gartner Group customers. So again, I have to redact some of what I show you, but it'll give you an idea of what the structure is that we use. So we could go to the next slide. And so the decision framework for virtual care services is laid out here. Again, I had to redact 4 of the sessions, but I do leave the legal and business case. So you get an idea of how this is viewed. But again, you start with the clinical service, you run it through the decision criteria, and then it funnels out to the care delivery spectrum. Is this better to be in person? Is it better solution to be in virtual care, or somewhere in the middle where it's a hybrid of the two? But the source of this, again, is the Gartner Group that was created. The decision framework was created in 2015. Next slide, please. So we took that and we created a suitability test for every new telehealth application. So this is just the template that we use. And again, there are 6 criteria, with legal and business case being 2 of them. And then we created a scoring system. Now, this is not something that Gartner provided, but we actually created a scoring system with a dashboard with red, yellow, green colors associated with it. And under each one of these criteria, you can see, so in the first line, there are actually 6 sub-criteria under that. And if we met the criteria for 5 or 6, then it gets a green highlight. And it also, you can see across the top, that category score of an 8. And so in the columns, the category scores are 8, 5, 3. And then if it's in the red column, you get a 0 score. And we actually have an automatic cancellation on any application that has even one of the criteria falls in the red category. You have to prove beyond a shadow of a doubt that the application is worthwhile. Next slide, please. And so this is just our low risk OB scoring matrix. And it just so happened to be that this scored in the green on all 6 categories. And it scored a maximum of 48 points. Again, this will be accessible to you so you could look at this further. We'll go to the next slide. And then this is simply our process. We develop a new idea. We complete the decision framework. It goes to the steering committee. If the steering committee rejects it, that application stops. If the steering committee accepts it, then it moves on to the outreach committee. And if it requires a capital expenditure, it moves on to IT governance. And only after something goes through this entire process will it be considered for deployment. Next slide, please. And so the last thing I'm going to cover is actually the first thing that Laura is going to cover is the telehealth program organization. In my case within Kentucky, we made a decision very early on to go with a very decentralized program. And by decentralized, I mean that the University of Kentucky has a telehealth program. We do not fund, we do not set up, we do not pay for any community-based telehealth program. So if a community-based hospital or clinic wishes to do telehealth, they do so at their pleasure. They pay for it, they set it up. It's not our responsibility to go after external funding. It's also not our responsibility, if we did fund that, to then have to come back every year and ask for a maintenance fee, a subscription fee, or something to keep that program going. The value of our decision to do that is that we're actually able to run our program with a very small staff. The downside is we have no control. So there's high autonomy at the community level, but very little control on our part. And that goes for the equipment, for the network. And then we talk just a little bit about integration, and that's integration into the medical record. And at this moment, we are moving to Epic, which has a very solid platform of telehealth integrated in it. But right now, our telehealth program sits outside the medical record. All the documentation occurs in the medical record, but it doesn't fully integrate. And then from a procedures perspective, our procedures mirror what we do in a traditional in-person clinic. So if a department schedules patients in a traditional in-person clinic, they do the same for telehealth. Or if they defer that to our centralized scheduling program at UK, then it's done there. But the telehealth office does not do any of those procedures. And then from a staffing perspective, again, we divested a lot of things out of our office. We don't have true technical support out of the telehealth office. Now, we have operational people, and we have technical people that understand the technology, but the vast majority of the technical support is going to come from traditional IT technical support people. And then from a workflow and processes perspective, the departments and the divisions that launch their telehealth program, they're responsible for creating the vast majority of the workflows and processes, because it's our intention that that should mirror exactly what they do in their traditional clinic. So Laura, I think you're going to pick up from that section and lead into your process.
Certainly. Thank you so much, Rob. Thank you, everybody, for joining us today. Rob, just to confirm, you can hear me okay, correct? Awesome. Thank you so much. So yes, thank you. Actually, Rob, I might have some questions for you as well. But in speaking to the state of Virginia, there are a lot of institutions that deploy and utilize telehealth, but I will be referencing UVA specifically. There's, as Rob mentioned, there's the centralized and decentralized, and they've chosen in Kentucky to go the decentralized route. But at UVA, we began with a centralized methodology. And so that allowed us quite a bit of autonomy, which was really wonderful in the sense of being able to develop a program that we felt could be very helpful. We looked towards our clinical representatives to help guide us in the sense of having those clinical champions sort of be the ones to help us determine how we should move forward in the sense of services to provide. But in regards to the equipment and the network, that is something that we manage. It is in partnership with our HID department, which we had originally been housed under. We started under HIT, which was really great. We always sort of called ourselves as budget dust compared to the rest of the IT department. So it gave us a lot more flexibility, be able to develop and test and try new things. But we have our own network that we manage, but it does reside behind our firewall. So it is safe, secure, making sure it's HIPAA compliant. One thing that we wanted to make sure of was that the systems that we use are standards based. As when Rob was mentioning about reaching out and establishing relationships, we actually at UVA have contracted with over 150 different partner locations, and we manage all of those contracts. And so those are ranging from the Virginia Department of Health, federally qualified health centers, critical access hospital, Department of Corrections, health systems. So we will partner with whomever we feel would be a great person or entity for us to collaborate with in providing care to patients. A lot of what we have been able to develop has been through grants. So we are heavy utilizers of grants, and we actually were able to establish the Center for Telehealth at UVA, which enabled us to have a little more weight to the grant process. So that's something that we've been able to help develop. And actually, we partner with research at UVA. So we've been able to bring a lot of funds into the institution through the grants from telehealth. Procedures, agree with Rob, we try to mimic as much as possible what the institution is doing in the departments. We definitely, in developing our programs, don't want something that's completely foreign. Otherwise, it's very challenging for individuals to adopt. Staffing, as I said, we're in-house, so not only do we have the engineers who manage the system, who support the providers, who install the technology, but also we have a business coordinator who manages the contracts and handles our accounts payable and receivables. We have a clinical coordinator who manages the scheduling of the different clinical programs that we have. That has migrated a little bit over the years, since a lot of the reasons for that is departments were saying they didn't have the staff, they didn't have the availability, they didn't have the time. So we were able to provide that for them so they didn't have to strain their current staff that they had. So that was something we wanted to be able to focus on for them. And then of course we have the project management and administrative staff to support the development of our different programs. And one thing I also want to comment, even though we were in HIT, it was a collaborative effort. So as Rob's mentioned, with the educational aspect, we collaborate with our continuing medical education department. We also collaborate with our billing department. As HIT as well, it's a very intimate relationship with our networking department and able to move forward. But a lot of that ownership and responsibility landed on us. Interestingly enough, even though we are going to be talking about the whole response to the pandemic, but that has required us to look at things a little differently, in the sense of moving more from a centralized to a hybrid model of centralized decentralization, just because the requirement of needing to care for our patients and having a greater access to telehealth by all of our providers, we were able to sort of collaborate even more closely with our project management office and our desktop services and our help desk, have them take some ownership off of that. So that way we could continue. Not only do we look to these partnerships, but we have a very large footprint within our health system of deploying technology, especially in our isolation units to support patient care there. So we needed to be able to focus our efforts on that while the rest of the health system sort of got revved up into the whole realm of telehealth. It's amazing how many clinical champions we gained in 3 months after working with handfuls of doctors over the 20-25 years that we've been in operation. But I wanted to go ahead and Rob touched on it a little bit, in the workflows and processes. You know, everybody has their own little rhythm about how they do things, and this is not necessarily specific to exactly how we do things as well. But you want to establish a process that you follow, sort of a template, as you know, Rob wonderfully shared. And there's also different project management methodologies. If you don't have a project management office, would highly suggest you know, at least have someone being familiar with project management. There's different styles, whatever fits your rhythm of your institution. Let me go ahead. And so in going through the process of what we go through, so the first step is always your needs assessment. What is a problem you're trying to solve or fix? You don't have a solution and then find a problem for that solution. You always want to first figure out what the problem is before you go out and purchase anything. And then prioritization, big picture. This is sort of going with the line with the strategy that Rob was saying. Does the problem that you're looking to solve align with the institution? So is the objective here remote patient monitoring, direct consumer, video consultation, education for providers and or patients. And then the champions. We always talk about having champions. You need to have champions in the organization who sees that problem and also is motivated and willing to work towards that solution. That sort of lines, the reason I put those two together is even though you may have a clinical champion who wants to do something, it may be not be a priority of the institution. So you sort of have to wait which programs and which projects you want to move forward on developing. And then goals. You first of all want to establish meaningful goals, and every goal in a project, especially if you're letting it run by the clinical department, everything is going to be essential, everything is going to be critical, and everything they must have. And so you have to make sure it's like what are the meanings behind those goals and what are the priorities of those goals, and then make them manageable. You can't deliver everything to everyone all the time. So you have to have a heart-to-heart discussion as to what is the prioritization in the sense of those goals, and measurable. You want to be able to measure at the end of this, what is it that you want to measure? How are you going to determine that you met your goals and objectives for this project? So you have to establish those measurements early on. And not devoid from going back to the management of it, scope creep is a huge thing that I just wanted to make sure of. Document these. You want to list these out so that way everybody agrees to them, like the strategic plan, business plan that Rob referenced. Include those measurements in that, as well as the goals and objectives that you're trying to reach. And then innovate. So look around, there could be collaborations that you could do with different institutions or different vendors of technology. So don't just look to what you have, but there are grants that can help you with the technology as well. So be innovative in your development of the solution to the program. Document, as I mentioned, document, train, and retrain. Having that information at hand is really important, and creating that consistency of your program development. And key things: establish roles and responsibilities. Especially we have found with the recent collaboration we have gone through within our desktop and process management office, is really assigning who's going to do what and moving forward. And it's really been a great collaboration, and that was part of the key, is making sure everybody is aware of who's supposed to do what and when. Accountability, don't work in silos. Again, collaboration is the key. Not only is it important to work with our different technology departments, but we've also found with our clinical departments, we've got to make sure that we've pulled everybody into the loop. You've got your providers, you have your schedulers, you have your billing people. They see this whole telehealth thing coming along and they're like, what is this? How do I bill for this? So you've got to make sure that everybody's included in the process to help garner success. And then evaluation or review. We like to pilot at UVA. We like to develop, work things out, test it out with a handful of people, get feedback, make modifications, tweak, update. We really prefer that methodology than the whole gangbusters, slam it out to the world type of an approach. It just helps when you're piloting, just to be able to refine and improve the product before you send it out into the world of your clinical and your partners, just because you want to avoid giving them a product that doesn't work or meet their needs. So by all means, find those champions who want to test it out, and it's really is a best method, if you can, to be able to follow. So when I was talking about documentation, not only do you want to have the strategic business plan in place that you want to follow and the project plan, but you also want the clinical workflow. And this is sort of what I'm going to reference in the sense you want to have the documentation. So there's different methodologies of workflows. You have the document where you could sort of like a checklist, you can write it out of all the different tasks and processes. And then the diagram, a graphical representation of that. And here's again too, you can have it as detailed or as an overview as possible. A lot of times we start with the overview and then break it down and go into the detailed version of it, because you want to get sort of an overarching thought of the process and how things work. And as both Rob and I mentioned, you want to mimic as much as possible with your telehealth program as what is being done in person. It just helps to keep with consistency and not so much of a learning curve, so to speak, for the team members. Applications, and the reason why I wrote this word, PowerPoint, Visio, most people know Word, some people know PowerPoint, very few people know Visio or have Visio. So keep that in mind when you're creating your workflows and your diagrams. I love Visio for diagrams. It makes it a lot easier, but not everybody has access to Visio. So if that's a tool you plan on using, you have to make sure to share as a PDF. And so just keep that in mind when you're developing these. And templates. Create a template, just sort of like we were showing, or Rob showed how he has a standard template that they use for developing a business plan. Same thing with your workflow. Come up with a standard workflow that you use and basically develop from there. And all of our telehealth programs have a templated workflow that I'm going to sort of show you an example of what we do. Oh, let me go back. Okay. So we a lot of times start with documentation in the sense of we will literally interview our clinicians, and both, not only the provider, but the schedulers. Consult request. How do you receive a consult request? Is that fax? Is it called? What do you do? What is that process? How can we be engaged with that? How do you validate that this is going to be a telehealth consult? So what are the steps in the process in that? How do you prepare for it? You know, what's the steps into performing the consult? And how is the connection going to happen? Performing the consult with a provider is sort of like when Rob was talking with us about his methodology, in the sense we do the same thing. Right now, we are not integrated into Epic, and apologies, I hadn't touched on that earlier, but that is something we're actually working on. That is our recent pilot that we're working with the technology department to develop an integrated technology solution within our EMR. So it's launched from within our EMR, but it's separate from the EMR. And historically, what we have been doing is having a separate application that the provider initiates from and then documents in Epic. So we're very similar in that, but we're trying to break out of that and try something a little different here. And then consult conclusion, you know, what are the next steps? You know, do you schedule the next appointment? Do you, you know, have the after visit summary printed? Who manages that? Because you have to take in consideration the patient's not right there. They're at the partner facility. So who is how's consult cancellation if the patient doesn't show, something happens at the facility, if the provider is sick? How do you, all those little steps that you think of. And here's the thing, not only do you need to take in consideration your patient, you know, where they're going to be, where the clinic, the providers, excuse me, what their role and responsibilities, but you have to consider the patient location at the originating site. So how are they engaged? So a lot of times what we'll do is we'll interview our clinicians, say, okay, you want to provide telehealth. This is great. Let's see how we can help you with that. And a lot of times what we'll do is look to our partner facilities. We'll go and figure out where their patients are located. And then we'll reach out to one of our partner locations and ask them, are you willing to engage in this pilot with us? And then we'll interview them, so to speak. Okay, how does this work for you? And fortunately, we have already established this templated process that we work through. So there's not going to be much of a difference for the partner facility. It's more so engaging and informing the new clinician that's decided to do telehealth. And then of course, telemedicine, we have our roles and responsibility. And the beautiful thing that we're working now doing this hybrid of centralized, decentralized, our steps in that process have greatly diminished because we are actually resourcing out to the clinical departments the scheduling aspect of it. Because of we have so many clinical specialties and so many providers, we still are providing that, I don't want to use the term barrier, but we're sort of that buffer between the clinical provider and the partner facility, because I cannot have every single clinician reaching out to one specific location to schedule their patients. And so we'll still be that coordination with our partner facilities so as to protect that relationship with them and have that continued conversation. Now, beautifully enough, some of our clinical specialists have gone and created sort of their own partnerships. So, hey, we've been talking with these guys, we want to set up a contract, we'll work with them and we'll develop with that. And then they sort of manage it all on their own in the sense of the scheduling and also managing the technology. It's actually really nice having that ownership taken within the clinical department itself. So that's the documentation. As you can see, you can get detailed, you can get an overview. Flow charts. This isn't specific to us, but you can have a basic flow chart in the sense of using different symbols and colors to mimic the process. A lot of times we'll use colors to designate either different roles and responsibilities of whether it's the partner facility function or whether it's the provider function or a telemedicine function. But just think of it in that methodology. Our actually, a lot of our clinics we find use this type of a flow chart, but we actually prefer a swim lane flow chart, and where you have the roles and it makes a clear delineation as to who's responsible for what and when through the process. So this is sort of our preferred, but also this is more easily done in Visio than it is in PowerPoint, so, or Word. So it's just a catch-22. And let me see, was that it? That was all that I had. I hope that was beneficial. we are given perfect. We have 15 minutes for questions and conversations. So hopefully, Ray, we have some questions that Rob and I can answer.
Yeah, thank you for the presentation. Absolutely. So I'm looking at the event Mobi Q&A function. I'm not seeing any questions come through. We actually do have one question. I'm sorry. I see the sessions are being recorded. Will we be able to get a copy or link to the recordings to go back and view again? From what I understand, yes, that should be made available after the conference is wrapped up. Attendees, please use the event Mobi platform to submit your questions.
And I actually have a question for you, Rob, if you don't mind.
Oh yeah, go ahead.
Okay.
Just in looking at your steering committee, I was wondering who is involved and engaged in your steering committee?
Yeah, it kind of grew organically, but it started out senior leadership, both on administrative and clinical side, but then it brought in strategy, contracting, legal, compliance. I mean, I think we're up to about 35 or 40 people now. But you know, what I can tell you, and I think people need to think about this, whether it is having a steering committee with this clear delineation of trying to find out what is the best application to prioritize, or getting on your strategic plan, it is a way to legitimize your program. Because so often, those of us in telehealth kind of, you know, they were put off to the side. You went after external funding to program your activities, and you kind of became this kind of self-sustaining project that goes and goes, but you don't always are at the table with senior leadership. And if you're able to do some of these things, you suddenly legitimize what you're doing as part of the enterprise. And once you're considered an enterprise resource, now you're at the table.
I must admit, we, as I had mentioned earlier, that we had started in the information technology department. And as part of a change in the strategic directive of our institution, we were actually moved out into operations. And even though that sort of, you know, we lost our budget dust sort of entity, it did help provide us a little bit more, you know, visibility to the institution. So it wasn't so much going to these specific clinical champions, but actually departments now reaching out to us and seeing us.
Well, see, we started in the College of Medicine, and then about 4 years ago, we moved to IT. But from our perspective, our CIO, she drives the bus. I mean, she is a powerful person within strategy within the organization. She drove UK to move to a new electronic medical record. And so it has been great value for our program to have an advocate that is as strong as she is. So again, wherever you land, take advantage of it.
That is true. I totally agree. In fact, actually, we're sort of trying out working through the chief medical officer right now, just because of the prioritization of the clinician engagement involvement. And oddly enough, with the integration effort that we've been trying to work through to in our EMR, our CIO has been incredibly supportive of us. And so it's really been nice sort of getting, you know, spreading our wings out and flying around a little bit. And it's actually helped to give us more visibility, more engagement from our leadership.
All right, so sorry, there we go. I do see a question in the Zoom chat, and I think both of you can speak to this. Are patients able to schedule their own telehealth visits online, or do they always have to speak to a scheduler? If they can, are there questions in place to determine if telehealth is appropriate for the visit?
Lauren, you want to start?
Sure, I'd be happy to. Certainly. So there are different mechanisms, and so direct to consumer, you would see that as being the patient being able to ask for the appointment, but we have not focused too much on that. That's something we're moving towards right now. But basically, we have looked towards referrals. So referral from our partner facilities, or actually referrals from we call them internal, external referrals. So we have externals from our partner facilities, and then we have internal referrals from our clinical providers who say, hey, I have this patient who drives 5 hours to get here. Is there a partner facility within which they can go to in order to receive telehealth? Because as you know, prior to the pandemic, there were heavy restrictions on where patients could be seen for reimbursement. Those were all wonderfully lifted, but we do not know how long those will stay in place. So we would always refer, we would engage a partner facility to ask if they could accept a new patient in for them to be able to receive the specialty care via telehealth through that way. Very few of our telehealth was done direct to consumer prior to the pandemic, and now the majority of what we're doing, of course, is direct to consumer patients. So that is a mechanism of a patient provider relationship. And the provider is the one who determines, one, first of all, if that patient can be seen via telehealth, if what they have to do for follow-up care with those patients is something that they can do via telehealth. And then we do have questions enabling our schedulers to sort of assess if that patient's technology would be viable for a telehealth consult prior to the physician trying to make that connection to them.
Yeah, it's so funny that Virginia and Kentucky, in some cases, the model is so similar, but we are both relatively established programs that started with exclusively community-based referrals back to the academic medical center. And so we very much mirror what Laura said. And as we kind of moved toward direct to consumer, and then COVID forced you to move to direct to consumer. We're still at a place where patients can call in and request an appointment, or we have an urgent care system where they can get an appointment immediately. But the vast majority, we don't have that. We're still waiting on Epic, which will be within the next year, but that fully automated schedule yourself, we're just not there yet.
All right, so I have another question coming through the chat. Can radiology doctors use AI algorithms as aiding tools to read x-rays through telehealth, teleradiology?
I'm going to give that one to you, Rob.
Yeah, I can't speak fully to that. What I can tell you is that we have a fairly significant diabetic retinal program, and they have done that group has done a really good job with some of the artificial intelligence that's able to look at retinal scans. In our case, they're always overread by providers, but I do think that our ophthalmologist let the artificial intelligence in some cases take a first look at it, but it's always read by a live person. And I just can't speak to radiology in general.
And that's actually very similar to us as well, Rob. We are same thing, ophthalmology, develop a program working with them. It's been wonderful for our rural communities to be able to receive that service. Radiology sort of developed their own program outside or in parallel to telemedicine. So they manage that whole process. So I'm not as familiar with the Department of Radiology, but I do know that they do a lot of store and forward, of course, in order to support patient care.
I don't mean to steal your thunder, but Tim is the one that asked the question. Tim, I work for the National Consortium of Telehealth Resource Centers, and Matrix, Netric, they fall under the umbrella. I know that the Southwest Telehealth Resource Center, and they cover several states in the Southwest, primarily Arizona. They do have a strong radiology background. If you want to reach out to them, telehealthresourcecenter.org is a good starting point to contact them. And I just wanted to put that out there if you want to look for resources for radiology. Okay, so I'm not seeing any other questions, so we'll give it a few seconds to see if anything else comes through.
Ray, one
Yeah.
of the things that I found interesting, and I think it really legitimizes what Laura talked about as far as processes, is that, and this whole idea of talking to everyone in the practice, including the schedulers and the people that we often look beyond, is that Press Ganey just did a webinar, I think it was earlier this week, and it was all about the changes that have occurred since COVID came out. And of course, Press Ganey is the consulting firm that looks at patient satisfaction, and they have some remarkable data. And I would say if you are a Press Ganey customer, you should look for this data. I haven't seen the UK data yet post-COVID, but the national data shows that patients love the providers. Like they come out of a telehealth direct-to-consumer visit, they love the provider, they hate the process. And I found that interesting. And the and the age group that was most satisfied with their telehealth visit, including process and provider, was the 0 to 17, which for the most part is mom filling out the Press Ganey survey for their child. And the most dissatisfied was 18 to 24, I think was that age. And I never would have imagined that. I would have think that they would have adopted to it, but they were the most negative on telehealth. So if you have an opportunity to look at that data, you should. It's really interesting stuff.
Yeah, thank you for that information. I'm definitely going to look out for that. So let's give it another minute. Now, I haven't seen any questions, and I wanted to offer to the attendees, we did this in our last session, that if you want to raise your hand, you can. This will allow you an opportunity to talk to the presenters and verbally ask your question. So let's give that 30 seconds and see if anything comes up. Oh, here we go. And one question came through the chat from Tyler Cornett. I see the sessions are being recorded. Will we be able to get a copy or a link to the recordings? Yes, I believe that the recordings and the slides should be made available once the conference is all wrapped up. And you should see some kind of correspondence from Kathy Wibberley or the Netric team. Yeah. Okay, so I'm not seeing any other questions come through the feed. I'm going to talk about this slide really quick. So we would really appreciate your feedback about this virtual conference. This is a very new field for a lot of people and definitely for us. So if you could, when you're navigating your way back through the EventMobi platform, when you're in the agenda and under the breakdown, the breakout session, if you scroll down the page, if you could click the session feedback button and provide us some feedback, we would really appreciate it. Next slide. And I think we should wrap up here. I wanted to thank our presenters for a great presentation today, and thank you to the attendees for joining this breakout session. Yeah, thanks everyone.
Thank you.
Thanks, Ray.
Yeah, all right, bye now.